Good evening, everybody. I'm Dr. Kohila. So today we'll continue with the rest of NEET-PG rapid revision. Okay. I'll read this for you. Which among these lymphoid organ develops in the dorsal mesogastrium? So you have given four options: A, B, C, D, histology. And there's one clue to it here. They have mentioned this is a lymphoid organ, isn't it? So yeah, can you figure out what is A, B, C, and D? Yeah. So what do you see here in picture A? You see a crypt. What is the lining of the crypt? Non-keratinized, stratified, squamous epithelium. Can you make it out? This is your lymphoid aggregate. This is mucus acini, isn't it? So these are the features of which lymphoid organ? Can you tell me? Of course, this is the picture of tonsil, palatine tonsil. Can you tell me where are the other places you get to see non-keratinized stratified squamous epithelium? This has been asked in one of your recent NEET-PG questions. Areas where do you get to see non-keratinized stratified squamous epithelium? Okay, remember the term. Oh wow, yeah. So it's the oral cavity, esophagus, vagina, and the lower part of anal canal. These are the areas where you get to see typically non-keratinized stratified squamous epithelium. So we are done with A. Now, can you tell me what is the development of tonsil? It comes from the endoderm of second pharyngeal pouch, isn't it? Okay. So it's not option A. Moving on to B. Can you tell me what is this? You see a lot of red and some amount of blue. Yes. Which lymphoid organ is this? Spleen. Yeah. So, spleen is made up of red pulp and white pulp. Which is majority, red pulp or white pulp? The red pulp. Okay. So, what is the white pulp made up of? The lymphocyte aggregation that you see here. Yeah. Okay. The lymphocytes, which consists of a eccentrically placed central arteriole, the lymphoid follicle. And then here all these red pulp that you see here, red pulp is made up of two components. What are they? The cords of Vellore are nothing but irregular cords of cells made up of the lymphocytes, yes, plasma cells, macrophages, reticular cells, and the splenic sinusoids. Do you know what is the special type of cells lining these splenic sinusoids? Normally, the endothelial cells are flat, isn't it? But these splenic sinusoids are lined by elongated endothelial cells. And what are they called? The stave cells. Yeah, they look like the barrel-shaped cells. And then, see, can you identify what is this organ? That's the thymus. Okay, here you can see the capsule, the septa, dividing it into thymic lobes. Okay, each lobe will have an outer darker cortex and inner pale medulla. What is the characteristic feature of the medulla here? The presence of Hassel's corpuscle. Yeah, double S double L. Okay, Hassel's corpuscle. Okay, now among these four lymphoid organs that you see here, how is the thymus different from the rest of it? Okay, normally the lymphoid organ, the skeletal framework is contributed by reticular fibers, isn't it? Reticular fibers. But in thymus, you have the reticuloepithelial cells, which form the structural framework. Okay, yeah, there are 6 types of reticuloepithelial cells. Hassel's corpuscle is contributed by the type 6 reticuloepithelial cells. Yeah, that's about the thymus. It's a primary lymphoid organ. Now coming to the last lymphoid organ that you see here, it's nothing but the lymph node. Okay, So you can see a nice septa there. This is the region of the cortex where you get to see the lymphoid follicle, and this area, that's the paracortex, and then this pale area is the medulla. So in the cortex of the lymph node, you have the lymphoid follicle aggregation. Yeah, the lymphoid follicle are mainly made up of B lymphocytes. What does the paracortex contain? The paracortex of the lymph node has two special features. It is made up of T lymphocytes, okay, and here in the paracortex you have something called as the high endothelial venules. Thymus is the area where the T lymphocytes mature, okay. These T lymphocytes reach the lymph node, paracortex of the lymph node via the high endothelial venules found in the paracortex. In the medulla, you will have the irregular cords of cells, the lymphocytes, as well as the lymphatic sinuses. So beneath the capsule, you have the subcapsular sinus, trabecular sinus, intermediate sinus, and then finally opening into the medullary sinus. Now you're okay with ABCD. A is tonsil, B is spleen, C is thymus, and D is lymph node. Okay. So A, you told me, is going to develop from the endoderm of second pharyngeal pouch, and B, spleen, that develops from the, yes, mesenchymal cells in the dorsal mesogastrium, right? Okay. What about thymus? The thymus develops from the endoderm of the third pharyngeal pouch along with inferior parathyroid gland. Superior parathyroid gland develops from the endoderm of fourth pharyngeal pouch. Lymph node is also derived from the mesoderm cell. Is that okay? Okay. Moving on to the next question. Which of the following is a branch of facial artery? 4 branches are mentioned there. Okay. There are a lot of questions related to tonsil, palatine tonsil. So you see, this is the palatine tonsil. They have talked about one superior tonsillar artery, inferior tonsillar artery. So this is superior, inferior, anterior, posterior. Okay. Superior tonsillar artery, inferior tonsillar artery, anterior tonsillar artery, yeah, posterior tonsillar artery. The superior tonsillar artery comes from greater palatine artery. Yes, remember that. The anterior tonsillar artery comes from the lingual artery, the second part of lingual artery, the dorsal lingual branches. They give rise to the anterior tonsillar artery. The posterior tonsillar artery, it arises from the ascending palatine artery, that's a branch of facial artery, and then also from the ascending pharyngeal artery, that's a branch of external carotid artery. And lastly, the inferior tonsillar artery that you see here, that also comes from the facial artery, right? Of these 4 arteries, which one is the principal arterial supply to the palatine tonsil? The inferior tonsillar artery. That's a branch from the facial artery, which is the principal arterial supply to the palatine tonsil. Okay, this is about arterial supply. There's another frequently asked NEET-PG question regarding the venous drainage of palatine tonsil. Okay, they have asked recently, isn't it? What is the vessel responsible for reactionary hemorrhage following tonsillectomy? Do you know the answer? Yes, the venous blood of the tonsil drains into paratonsillar vein. Okay, and it has another name called the external palatine vein. Yeah. So everything about tonsil is very important. Make sure you read it. Arterial supply, venous drainage. Any idea about the lymphatic drainage? The jugulo-digastric lymph nodes. Okay. They are the principal lymph nodes of the palatine tonsil. What about the nerve supply? The glossopharyngeal nerve. Also the greater and lesser palatine branches coming from the pterygopalatine ganglion. They also supply the palatine tonsil. Yeah, development of tonsil we have seen from the second pharyngeal pouch. Another thing that I want to tell, which has been also asked, the Tonsilla bed. Okay, So, this is the tonsil here. Yeah. The medial surface of it is going to be covered by mucosa. What are the structures that form the bed for the palatine tonsil? Okay, immediately in the lateral wall, you'll get to see the loose areolar tissue with the paratonsillar vein. Okay, the paratonsillar vein embedded in the loose areolar tissue just lateral to the tonsil. Yes, after that, you'll get to see, I'll take a green color, the pharyngobasilar fascia. Okay, normally you have a buccopharyngeal fascia, the constrictor muscles, longitudinal muscles, and then the pharyngobasilar fascia. So we are going from inner to outer now. The pharyngobasilar fascia, I'll take a brown color. Then the upper part, you'll get to see the palatopharyngeus muscle. And then mainly in the lateral wall, you'll get to see the superior constrictor muscle. One more fascia, what did I tell? The buccopharyngeal fascia. Okay. Now, outer to that, there are some important arterial relations. You'll get to see the ascending palatine artery, okay, the ascending pharyngeal artery, and even the internal carotid artery, like 2.5 centimeter lateral to the palatine tonsil. I'll label it, guys, okay. So remember, it's the paratonsillar vein in the loose areolar tissue, pharyngobasilar fascia. I've drawn two green color, isn't it? Pharyngobasilar fascia, buccopharyngeal fascia, the superior constrictor muscle, okay? Even the styloglossus part of it you can see. This is your ascending palatine artery from the facial artery. This is ascending pharyngeal artery. This is your internal carotid artery. All these structures, they form the lateral relation of the palatine tonsil, forming the tonsilla bed. Same thing is seen here. Can you see here? This is your palatine tonsil. This is your paratonsillar vein. This is your pharyngobasilar fascia, paratonsillar vein. This is your pharyngobasilar fascia. You get to see the superior constrictor muscle, buccopharyngeal fascia. You can see the inferior tonsillar branch of the facial artery piercing the superior constrictor muscle. Okay, we'll move on to the next question. Occlusion of the artery supply of the marked area will cause. So what is the marked area here? Can you see that yellow dotted line here? What is it? Can you tell me? Yes. What surface of cerebrum is it? You're getting to see the medial surface of cerebrum. Yeah, this is the central sulcus. This area surrounding central sulcus is called the paracentral lobule. What is special about this paracentral lobule? Okay, the anterior part of it will be continuation of your precentral gyrus, that is motor in function, and the posterior part of it will be continuation of the postcentral gyrus, that is sensory in function, isn't it? Okay. Now, what is the part of the body that is represented here? That is important. Okay. So, the lower part of the body, including the perineum region, yeah, lower limb, the perineal region, the anal region, okay, all that will be represented in this paracentral lobule. So, in this question, they've asked what will happen when there's occlusion of the artery supplying this area. Astereognosis is the function represented in the superior parietal lobule, area 5 and 7. Okay. Motor aphasia, that's in the inferior frontal gyrus, area 44 and 45. Intentional tremor is characteristic of your cerebellar lesion. Okay. So urinary incontinence, okay, problem with defecation, micturition will result when there is lesion of the paracentral lobule. Which of the following arises from the cervical part of facial artery? Suprahyoid artery, superior laryngeal artery, ascending palatine artery, infrahyoid artery. So we'll quickly see about the branches of facial artery. Okay. So you know that the facial artery, it arises from the external carotid artery in the carotid triangle, isn't it? Yeah. What are the branches of external carotid artery in the carotid triangle? Superior thyroid artery, that's the first branch. Ascending pharyngeal artery, yeah. And then you have the lingual artery, facial artery, occipital artery. 5 branches of external carotid are given off in the carotid triangle. Okay. This will be given off just above the tip of greater cornu of hyoid bone. What level does the common carotid bifurcate into external carotid and internal carotid? At the upper angle of thyroid cartilage, C3, C4, okay? The facial artery arises above the tip of the greater cornu of hyoid bone. What is happening to it after that? So this facial artery is going to wind around the posterior border of the submandibular gland. It will run between the medial pterygoid and the submandibular gland. Then it will loop around the lower border of the mandible to reach the face. It will be related to the antero-inferior angle of masseter. When you clench your teeth, you can feel your masseter, isn't it? Okay, this part. It will be related to the antero-inferior angle of masseter. This area is important. At this part, it will be crossed by 2 important structures. Marginal mandibular branch of facial nerve, which is going to supply the muscles of lower lip, okay, as well as the facial vein. And then it will ascend up and terminate near the angle of KI, the medial angle of KI, as the angular artery by anastomosing with dorsal nasal branch of ophthalmic artery. Now, in the cervical part of the facial artery, remember the mnemonic tags. Okay, 4 branches are given off. What are they? Just now we saw, isn't it? The inferior tonsilla branch supplying the palatine tonsil. And then, yeah, you get to see the ascending palatine branch of facial artery, and then glandular branches to supply the submandibular gland, and then submental branch. Okay, remember the mnemonic. Cervical part, tags. Facial part is easy. Lassi. Okay, inferior labial branch of facial artery, superior labial branch of facial artery, lateral nasal branch of facial artery, and then it terminates as angular artery, right? So they are frequently asked questions related to branches of external carotid artery. Recently they've asked, isn't it? Which is the first branch of external carotid artery? Superior thyroid artery. The only medial branch coming from external carotid artery is the ascending pharyngeal artery. Okay. What are the branches of superior thyroid artery? We'll quickly go through the branches alone. Yes. Superior thyroid artery. Superior conquered the government of South India. Okay, just a mnemonic. The superior conquered government of South India. So what are the branches coming from here? I'll remember it in order actually. It is given off below the tip of the greater corner of the hyoid bone. So infrahyoid branch will be the first. Then it will give rise to superior laryngeal artery. What happens to the superior laryngeal artery? Along with the internal laryngeal nerve, it pierces the thyrohyoid membrane. It will also give rise to the sternomastoid branch to supply the sternomastoid muscle, cricothyroid branch, and then lastly, glandular branches to supply the thyroid gland. What is the nerve accompanying superior thyroid artery? External laryngeal nerve. What is the relation between the nerve and the artery? The nerve will be actually postromedial to the artery. Okay, the two will be accompanying closer together. Only on reaching the thyroid gland, they will move apart. So the best place to ligate the superior thyroid artery will be close to the gland. Okay, so we are done with this. We'll move on to the next one. Ascending pharyngeal, I told you that's the only medial branch coming from external carotid artery. Ascending mountain is powerful. So what are the branches coming from here? We'll have a meningeal branch, a pharyngeal branch, and an inferior tympanic branch. Right? These are the three branches coming from the ascending pharyngeal artery. Lingual artery. What is the name of the muscle dividing the lingual artery into three parts? Hypoglossal. Okay. So the lingual artery will arise at the level of the tip of greater corner of hyoid bone. From the first part, yes, you'll get the suprahyoid branch. From the second part, which lies beneath the hypoglossal muscle, you'll get the dorsal lingual branches that will give rise to anterior tonsillar branches. And from the third part, okay, you'll get the sublingual branch. The sublingual branch will be accompanied by lingual nerve. Okay. The first part will be crossed by your hypoglossal nerve. Right? And then what is the next one? Facial artery we have seen. Occipital artery. Okay. You'll get the mastoid branch, muscular branches, meningeal branch to supply the posterior cranial fossa, sternomastoid branch, and the descending branch. Okay. Posterior auricular is nothing much, but remember the stylomastoid branch, auricular branch, and occasionally occipital branches will arise from this. What is the terminal branches of the external carotid artery? Superficial temporal, which will ascend up, and the maxillary artery. Branches from the superficial temporal artery, PT Maza. Okay. So I'll write it in order as I remember that. First branch will be the transverse facial artery running along the face horizontally. Transverse facial artery. Above that, you'll get the anterior auricular artery. Easy, guys. And then zygomatico-orbital artery. Okay. Yeah. And then you have the, remember, the anterior frontal, middle temporal, posterior parietal. Okay. From front to behind. Anterior frontal, middle temporal, posterior parietal. Anterior frontal, middle temporal, and posterior parietal. These are the branches of superficial temporal artery. Okay. And then maxillary artery, that's the largest branch of your external carotid artery. That's again going to be divided into three parts by which muscle? Lateral pterygoid. Okay. From the first part, we have four branches. Okay. Middle meningeal artery, accessory meningeal artery, inferior alveolar artery, and deep auricular artery. From the second part, to supply the muscles of mastication, buccal branches. You know the name of the four muscles of mastication, isn't it? So you can write it. Buccal branches, masseteric branches, pterygoid branches, and temporal branches. Okay. From the third part, okay, the branches are, okay, postero-superior alveolar artery, yes, and then the second one, artery of pterygoid canal, okay, pharyngeal branch, yeah, infraorbital artery, greater palatine artery, and sphenopalatine artery. Right? Okay, guys, we had a quick revision about the branches of external carotid. First part, the mnemonic is MAID, maid. Okay. The third part, Peppa Pig. Yeah. And the second part, muscles of mastication. We'll move on. So here back to the MCQ. Which of the following artery arises from the first cervical part of facial artery? Suprahyoid, can you tell me it is the branch of lingual artery? Superior laryngeal artery is a branch coming from superior thyroid artery. Ascending palatine from the cervical part of facial artery. Yeah. Infrahyoid is again from superior thyroid artery. Okay, guys. Okay, moving on to the next question. Which is correct about the renal arteries? Okay, they are end arteries. Medulla has more blood supply than the cortex. Arcuate arteries anastomose with each other. Anastomosis takes place at lobar level. This also has been asked recently in your NEET-PG question. Okay, the blood supply of kidney. So you know that the arrangement of structures at the pelvis from anterior to posterior is you have the renal vein, renal artery, and then the pelvis of the kidney. Okay. So now what is happening? The right and the left renal artery, yes. Now as they enter, they are going to divide into segmental artery. Okay. Segmental artery. This segmental artery will further divide into lobar artery. Okay. You have the renal artery that's going to enter the kidney. It's going to divide into segmental artery. Segmental artery will divide into lobar artery. Okay, this lobar artery will give rise to interlobar branches that will pass between the pyramids. As you see here, between the pyramids. And then on reaching the top of the pyramid, that will give rise to arcuate arteries. But the special thing is that these arcuate arteries do not anastomose. Okay, they'll give rise to fine branches that will ramify beneath the capsule. Okay. So these are the segments, the vascular segments of the kidney. Apical, basal, upper anterior, middle anterior, and a posterior segment. 5 vascular segments. Yeah. Apical, basal, upper anterior, middle anterior, and posterior. There is one plane. Can you see here? Okay, it's called the bloodless plane. Okay, or the Brodell's line. So the only correct answer here is the renal arteries are end arteries. The cortex receives much more, 4 to 5 times more than that of the medulla. The arcuate arteries do not anastomose with each other. Okay. Which, this also has been asked recently, which among the following lies intersegmental in a bronchopulmonary segment? So what do you see here? Lung. Which lung? Right lung or left lung? This is the right lung. Okay, you're seeing the mediastinal surface. Now, can you identify these 4 structures? Okay, so the one A, which is posterior most, that's your bronchus. So the bronchus, the right side, the bronchus will divide into eparterial bronchus, hyparterial bronchus, even before it enters the lung. This will be your eparterial bronchus, the hyparterial bronchus. What is shown here in B is the pulmonary artery, which carries deoxygenated blood, and the C is your superior pulmonary vein. D is the pulmonary plexus of nerves. Right? This one, can you identify what is this one? This is pulmonary ligament. So you see the pulmonary ligament, the vessel that lies immediately on top of the pulmonary ligament, that will always be the inferior pulmonary vein. Okay, you need not confuse at all. You see the pulmonary ligament, just on top of it, you'll get to see the inferior pulmonary vein. And the arrangement of structures at the hilum from anterior to posterior will be vein, artery, bronchus. So the bronchus is the posterior most, The superior pulmonary vein will be the anterior most, and you have the pulmonary artery there in between. Okay, and the arrangement of structures from above below will be artery, bronchus, and vein. In the right side alone, it will be epiarterial bronchus, pulmonary artery, and then the inferior pulmonary vein. Okay. Okay. Now coming, so you have identified A, B, C, and D. Okay. Can you tell me what is bronchopulmonary segment? So you have the trachea dividing into right and left principal bronchus, isn't it? The right or the principal bronchus will further divide into lobar bronchi, right? So how many lobes are there in the right lung? 3, isn't it? Upper lobe, middle lobe, and lower lobe because of the presence of a horizontal fissure in addition to your oblique fissure. So this lobar bronchi will be called as the secondary bronchus. Primary bronchus or the principal bronchus dividing into 3 lobar bronchi on the right side and 2 on the left. Now what is happening to this lobar or the secondary bronchus? They are going to further divide. Okay. These further divisions will be called as the tertiary bronchi or the segmental bronchus. So how will you define bronchopulmonary segment of lung? The portion of the lung which is aerated by a tertiary bronchus or segmental bronchus is called bronchopulmonary segment. Okay. How many others? There was another question again. How many bronchopulmonary segment on the right lung and on the left lung? 10 on the right, 10 on the left. Do you know their names? The upper lobe of the right bronchus has the apical segment, okay, posterior segment, anterior segment, upper lobe. The middle lobe will have lateral and medial segment, and the lower lobe will have apical basal, anterior basal, lateral basal, yeah. Then you'll have a medial basal and posterior basal. 3 in the upper lobe, 2 in the middle lobe, and 5 in the lower lobe on the right lung. The left lung, what happens? Excuse me. Again, supposed to have, okay, apical, posterior, anterior. Okay, then you have a superior lingular, inferior lingular, and same 5 segments in the lower lobe. Apical basal, anterior basal, lateral basal, medial basal, posterior basal. But what can happen in the left lung is that the apical and the posterior segment, they can be aerated by a single bronchus, single tertiary bronchus or segmental bronchus. In that case, it will be called apico-posterior segment. And also in the lower lobe of the left lung, the medial basal segment can sometimes be absent. So in the left lung, though normally 10, it can range from 8 to 10. Got it? And the next thing coming to our MCQ. So this is your bronchopulmonary segment, wedge shape. So the apex of the wedge will be facing the entrance of the tertiary bronchi, and the base of the wedge will be on the surface of the lung. As you see here, this is the tertiary bronchus entering the bronchopulmonary segment. Okay, it's accompanied by the, what you see here, blue will be the pulmonary, artery will be there, and the bronchial vessels also will be there. Here, intersegmental, can you see here? Intersegmental between two adjacent bronchopulmonary segment, what lies is the pulmonary vein. Okay, intersegmental vein. So that was a question, right? Yeah. So here, C. The pulmonary veins are intersegmental in position in bronchopulmonary segment. Okay. Now, what is a true statement regarding ciliary ganglion? Option A, situated between optic nerve and medial rectus. Motor root is from inferior oblique. Parasympathetic is Edinger-Westphal nucleus. Sympathetic root is supplying sphincter pupillae. Okay, few words there about the ciliary ganglion. Here, situated between optic nerve and lateral rectus, isn't it? Motor root is from inferior oblique. Parasympathetic root is coming from Edinger Westphal nucleus. Sympathetic root, okay, is coming from plexus around your internal carotid artery. Yes. So here, these are all the true statements, B and C. Now, okay, lacrimation is affected in injury of greater petrosal nerve. Similar question. In fracture of middle cranial fossa, absence of lacrimation will be due to lesion in. So they have asked it repeatedly. I would like to discuss with you certain things now. So what are the 4 parasympathetic ganglia in head and neck? Ciliary ganglion, otic ganglion, pterygopalatine ganglion, submandibular ganglion. Okay, a lot of MCQs are surrounding this topic. So I'll make a table for you to remember the facts. Yeah. So size. Which do you think is the largest of these parasympathetic ganglion? The pterygopalatine ganglion is the largest of the peripheral parasympathetic ganglia in head and neck. Smallest, the ciliary ganglion, is the size of a pinhead. Otic ganglion will be around 2 to 3 millimeter. Okay. Now coming to the location. Where do you get to see the ciliary ganglion? Just now we saw, isn't it? Apex of orbit. Sandwich between which two structures? Lateral rectus and optic nerve. Where do you get to see otic ganglion? In the infratemporal fossa. Okay, remember the relations here. So this is the foramen ovale. Mandibular nerve is coming out of it. Okay. Here you have the tensa veli palatini muscle, TT. Yes. Here you have the nerve to medial pterygoid that is surrounded by the otic ganglion. Now you get to see the middle meningeal artery. The otic ganglion lies in front of the middle meningeal artery and then behind the medial pterygoid muscle. Okay, so you have to remember TTMM, relation for otic ganglion. Okay, medially tensa veli palatini muscle, laterally trunk of the mandibular nerve. In front, medial pterygoid, behind middle meningeal artery. These are the relations of otic ganglion, right? Pterygopalatine ganglion, where does it lie? In the pterygopalatine fossa. Submandibular ganglion will rest on your hypoglossal muscle, right? Okay. Now, any ganglion, if you see, it will be topographically related to a particular nerve and functionally related to another nerve. So, functional relation is easy. The mnemonic is COPS. Okay. 3977. Okay. COPS. COPS 3977. Remember that. For functional nerve related to the ganglion. Topographical relation of the nerve. Ciliary ganglion topographically will be related to nasociliary nerve, which is a branch coming from ophthalmic division of your trigeminal nerve, right? And then here, what is the topographical relation? For the otic ganglion, it will be closely related to the mandibular division of the trigeminal nerve. Pterygopalatine ganglion will be related closely to the maxillary division of the trigeminal nerve. Submandibular ganglion will be actually suspended by the lingual nerve that's coming from the mandibular division of trigeminal nerve. Next, you should remember that this parasympathetic ganglia, okay, it is going to allow the parasympathetic fiber to pass through it, the sensory and sympathetic fiber to pass through it, okay. It will have a parasympathetic root, sympathetic root, as well as a sensory root, okay. And of the 3 roots, the only one synapsing in this ganglia will be the motor or the parasympathetic root. All the others will Yeah, all of them will leave as postganglionic fibers. But the only one synapsing will be your parasympathetic fibers. Okay. So you have to write the parasympathetic or the motor root. So it will be coming, these preganglionic fibers will be coming from some nucleus, right? And then it will have a sympathetic root and some might also have a sensory root. Okay. So for ciliary ganglion, the parasympathetic root is nerve to inferior oblique. Yes, nerve to inferior oblique. What is the nucleus it's coming from? The Edinger Westphal, the oculomotor nucleus, right? Nerve to inferior oblique. Yeah. The parasympathetic nucleus is your Edinger Westphal nucleus. The sympathetic component will be plexus around internal carotid artery or the ophthalmic artery, which is a branch. Sensory root will be from the nasociliary nerve. Right. Okay. And the postganglionic fibers which are going to come, the postganglionic fibers, they form the short ciliary nerves. Okay. The short ciliary nerves, they are going to supply, yes, the sphincter pupillae as well as the ciliaris muscle. Okay. So that's about the ciliary ganglion. So this table will summarize for you nearly everything, isn't it? Size of it, location, topographical, functional nerve related, parasympathetic or the motor root, sympathetic sensory root, postganglionic fibers, structure supplied is sphincter pupillae, constriction of pupil, ciliaris muscle of accommodation. Right? Now coming to the aortic ganglion. Yes, aortic ganglion. Okay. So here the parasympathetic root is going to be coming from lesser petrosal nerve. Okay. This lesser petrosal nerve is synapse in the aortic ganglion. And nucleus is coming from the inferior salivatory nucleus. Okay, remember, this is going to finally supply secretomotor pathway for your parotid gland. So the parotid gland receiving secretomotor fibers coming from inferior salivatory nucleus. Whereas the one below, the submandibular and sublingual salivary gland gets innervation coming from superior salivatory nucleus, right? Okay. Sympathetics will be around the plexus around the internal carotid artery again. Yeah. And the postganglionic fibers, they pass through auriculotemporal nerve, right? Coming to pterygopalatine ganglion, yes, the parasympathetic root will be nerve to pterygoid canal. Okay. Sympathetic will be deep petrosal nerve. Now, which one is going to synapse in the pterygopalatine ganglion here? The nerve to pterygoid canal. And the postganglionic fibers will come out through the, yes, zygomaticotemporal, that will be conveyed through the lacrimal nerve to the lacrimal gland. There are also other branches coming from the pterygopalatine ganglion, which will supply the orbit, the nasal cavity, the palate, as well as the pharynx. What is the other name for pterygopalatine ganglion? The hay fever ganglion. Okay. Stimulation of that is what will happen? Lacrimation. Yeah. Then submandibular ganglion. What will be the parasympathetic root here? You know, the chorda tympani is going to join the lingual nerve, isn't it? Nucleus, as I told you, is coming from the superior salivatory nucleus. Yeah. So the lingual nerve will be suspending the submandibular ganglion. The postganglionic fibers that leave the submandibular ganglion will directly supply your submandibular gland. Okay. Whereas few other fibers will pass through the lingual nerve to supply the sublingual salivary gland. Okay. So there are a lot of MCQs related to this topic. Make sure you know it. Another name for submandibular ganglia is called the Langley's ganglia. Okay. Coming to the next question, sensory innervation of pyriform fossa. Okay. So which is, first let's know where is the pyriform fossa. What is this you see here? Image based question here. This is the sagittal section of head and neck. So let's figure out what are all that we see here. Can you tell me what is this? That's your frontal sinus opening into middle meatus. This is your sphenoid sinus. What is this you see here? The nasal septum. What are the bones contributing to the nasal septum? The anterosuperior part that's formed by perpendicular plate of ethmoid. And in the postero-inferior part, it's contributed by omer, right? So this is your hard palate. This is your soft palate. What is this area that you see here? The nasopharynx. What is that in the lateral wall of the nasopharynx? That's the pharyngeal opening of the auditory tube, right? This is your oropharynx. This is the region of laryngopharynx. What is the extent of pharynx then? From C1 to C6. Below that will become continuous with your esophagus, right? So this is, you can see the anterior arch of the atlas, the dens of axis, okay? So up to C1, C2 will be the posterior extent of your nasopharynx. From C1 to C6, this is your tripod here. So yeah, this will be your C6 vertebra. Below that will be continuous with the esophagus. Larynx will become continuous with the trachea. Pharynx will become continuous with the esophagus. What is the muscle that you see here? Genioglossus. It is also called the safety muscle of the tongue. Why so? Because it protrudes the tip of the tongue. Yeah. If it goes for paralysis, the tongue will fall back and occlude your respiratory passages. This one here is geniohyoid. Any idea what is its nerve supply? C1 fibers, which also supplies the thyrohyoid muscle. Now, in this section, can you tell me where is pyriform fossa? Where do you expect to see it? In the lateral wall of your laryngopharynx, okay? Now, I want you to understand this image also very well, okay? So, what are the things you can see here? This is the region of your nasal cavity, posterior aspect of the nasal cavity. This is the posterior aspect of the oral cavity. This is your laryngeal inlet. Am I right? Okay. So this is actually the pharynx that's been opened up. Yeah. So the region of nasopharynx, oropharynx, and the laryngopharynx. So what are the structures you get to see here? Whatever possible, we'll identify. Okay. So what do you think this is? This is the roof of the nasopharynx where you get to see the nasopharyngeal tonsil or the adenoid. Can you see that? This one pointed. This is your nasal septum. It's posterior aspect, so probably omer. What are these shelf-like projections that you see here? The concha in the lateral wall of the nose, right? Okay. Can you tell me what is this structure here? That's the opening of your auditory tube in the lateral wall of nasopharynx. And you see two folds coming from that. Can you see here? One here and one going down. This structure is soft palate. So this fold, which is going towards the soft palate, what will it contain? Any idea? This one going towards the soft palate will contain the salpingo-palatine muscle. Okay. This one going downwards, the longitudinal muscle of the pharynx, salpingopharyngeus. Right? Can you identify the uvula here? So far, okay? Now coming down. Yes, this is the uvula. Can you tell me what is this you see here? Of course, it's the tongue. Which part of the tongue? The posterior most part of the tongue with the lingual tonsil. Yeah, part of your Waldeye's ring. And in the lateral wall of the oropharynx, what is this that you see here? Can you see something peeping out? That's your palatine tonsil. Now, can you tell me what is this arch? Yes, from the palate going down, palatopharyngeal. It has the palatopharyngeal muscle, this fold, okay? Lateral wall of oropharynx. Now coming to the laryngeal inlet, this is your epiglottis. You saw the epiglottis? Yeah. This is the cricoid. So I'll label it. This is epiglottis. This is the posterior part of the cricoid cartilage, the posterior broad lamina of the cricoid cartilage. On top of it, you expect to see the arytenoid. Can you make out two nodular structures here? These are the corniculate and cuneiform cartilages, right? Corniculate and cuneiform cartilages. Now tell me, what is this fold? Yeah, that's the aryepiglottic fold. Yeah, which has the aryepiglotticus muscle, thyroepiglotticus muscle, the corniculate and cuneiform cartilages. Okay. And then, now where is the piriform fossa? You have seen it there. It lies lateral to the aryepiglottic fold in this area. This is your thyroid lamina, the mucosa covering the thyroid lamina. So the boundaries of the piriform fossa will be medially aryepiglottic fold, laterally the mucosa covering the lamina of the thyroid cartilage. Okay. And then above also the thyrohyoid membrane. So what is the structure traversing it? Can you see it here? A nerve passing through that, the internal laryngeal nerve. Okay. So this internal laryngeal nerve along with the superior laryngeal vessel will be a content of the piriform fossa. Okay. So this MCQ, sensory innervation of the piriform fossa is by internal laryngeal nerve. This internal laryngeal nerve also supplies the mucosa of larynx above the level of ocal fold. Yeah. Recurrent laryngeal nerve, it supplies all the muscles of larynx except cricothyroid, that is supplied by external laryngeal nerve, right? Also, it is sensory to the mucosa of the larynx below ocal fold. Okay. Glossopharyngeal nerve, what does it do? It supplies only one muscle, tylopharyngeus. Okay. So in head and neck, you must be knowing all and except, is it? All muscles of tongue supplied by hypoglossal nerve except palatoglossus, that is supplied by pharyngeal plexus, which is contributed by 9, 10 and cranial part of accessory nerve. Okay. All muscles of palate supplied by pharyngeal plexus contributed by 9, 10, 11 except tensor veli palatini, that is supplied by the mandibular division of trigeminal nerve. All muscles of pharynx are again supplied by the pharyngeal plexus 9, 10, 11 except stylopharyngeus, that is supplied by glossopharyngeal nerve. Okay. All muscles of larynx, just now we saw, it is going to be supplied by recurrent laryngeal nerve except cricothyroid, that is supplied by external laryngeal nerve, right? Okay. Now there was a question recently asked, what is the name given to the interior of the larynx that you see above the level of the vestibular fold? Okay. So we'll just go have a quick revision about the interior of the larynx or the cavity of larynx. What are the things that you get to see here? Yes. So here this is your epiglottis. This is your epiglottis, right? Okay. Now can you tell me what is this one? This is your hyoid. Okay. This is your thyroid cartilage, right? And this is your cricoid. This is your tracheal ring. Okay. Epiglottis, hyoid, thyroid, cricoid, and tracheal ring. I'll rub it and move on to the next part. Okay. Can you tell me what is this structure connecting the hyoid and the thyroid? The thyrohyoid membrane. The thyrohyoid membrane is pierced by superior laryngeal vessel and internal laryngeal nerve. Okay. And then here, can you see a ligament, something like that here? This is your quadrate ligament. Okay. And another ligament you get to see here, that is your cricooccal membrane. Quadrate membrane. The lower part of the quadrate membrane is thickened to form the quadrate ligament, and the mucosa covering this is called the vestibular fold, okay, or the false ocal cord. This is your cricooccal membrane. The upper part is thickened to form the ocal ligament, and the mucosa covering that will be called as ocal fold. Okay. Do you want me to repeat it again? Yes. Quadrate membrane, lower part thickened to form the quadrate ligament, mucosa covering this is your vestibular fold or the false ocal cord. The upper part of the cricooccal membrane or conus elasticus thickened to form the ocal ligament, mucosa covering that will be called as the ocal, the true ocal fold. Remember another MCQ related this vestibular fold will be lined by ciliated columnar epithelium. Most of the larynx will be lined by ciliated columnar epithelium, except in the region of the ocal fold, the mucosa is lined by non-keratinized, stratified, squamous epithelium. Okay, please remember that. Okay, now coming to label the spaces. This space, the space that you see above, the space that you see above the vestibular fold, that is going to be called the supraglottic part or the vestibule of larynx, right? Below the ocal fold will be called the infraglottic part. Now this space between the ocal fold below and the vestibular fold above is called sinus of larynx. Now, in the region of the sinus of larynx, can you see an outpouching here? So there's a ligament above and ligament below, but here you can see that there's a mucous diverticulum extending out. This area is called saccule of larynx, which will be like filled with lot of mucus secreting glands. Okay. Okay with the term supraglottic or vestibule, infraglottic, sinus of larynx. Okay. Yeah. Epiglottis. Now, the space between the two vestibular folds is called rhima vestibuli. Okay. The space between the two ocal folds is called the rhima glottidis. That's the narrowest part of your larynx. Okay. One more thing I want to tell you. The laryngeal inlet, the boundaries of the laryngeal inlet, it's formed by on either side by the ariepiglottic fold, in front by the upper border of the epiglottis, behind by the interarytenoid fold of mucous membrane. Okay. Identify the structure that is not related to cystohepatic triangle. What is the other name for cystohepatic triangle? It is also called the Callus Triangle, right? Yeah. So which is the one which is not related to here? We'll see that. So this has been asked repeatedly in your entrance exam. The Callus Triangle, which is bounded above by the inferior surface of the liver. Inferior surface or the border of the liver, medially by the common hepatic duct, below by the cystic duct. Okay. Inferior surface of liver, common hepatic duct, below by the cystic duct. Now, what are the components that are present within the Callus triangle? You get to see the right hepatic artery, which will give rise to cystic artery. Okay. And the lymph node present here is called the cystic node of Lund. The cystic artery will be situated just behind the lymph node. So this Callus triangle surgical importance is that this is the area where you get to ligate the cystic artery, okay? Because it could cause lot of bleeding problem during cholecystectomy. So the answer here will be left hepatic artery. Wilkie syndrome is related to celiac trunk, superior mesenteric artery, inferior mesenteric artery, none of the above. So what is that Wilkie syndrome? Before that, remember few relations. So this is your pancreas, the head, neck, body and tail of pancreas, right? This is your uncinate process. What is the anterior relation for the uncinate process? You see the superior mesenteric vein, superior mesenteric artery. Superior mesenteric artery is coming from abdominal aorta, vertebral level, L1, right? Now the pancreas has been removed. Okay, what do you get to see here? This is the third part of the duodenum. Third part of the duodenum that's crossed by your superior mesenteric vessel. Now something important relation to be remembered here. Okay, so this is your abdominal aorta that's going to give rise to the superior mesenteric artery. Three structures are sandwiched between the abdominal aorta and the origin of superior mesenteric artery. From above below, what you see here is the left renal vein and then the uncinate process of pancreas and the third part of duodenum. Okay. So compression of these structures can result in a lot of clinical symptoms. That is called as the Wilkie syndrome. Main thing will be compression of the third part of duodenum leading to duodenal scasses. So our question here is Wilkie syndrome related to superior mesenteric artery. The structure which lies beneath hyoglossus is lingual artery, lingual nerve, hypoglossal nerve, submandibular ganglion. Which one? So which is hyoglossus muscle here? You see the tongue here. This is your mandible. Okay. Now this is your hyoid. You see these vertical fibers running here from the hyoid upwards to the side of the tongue. This is the hyoglossus muscle. Okay. So okay with the hyoglossus muscle? Yeah. Now, what are the other structures that you get to see here on top of hyoglossus muscle? You see a nerve running transversely in front of the hyoglossus. That is your hypoglossal nerve. Okay, please remember the hypoglossal nerve, which will be accompanied by the venae commitans. Okay, this is a very important image-based question. Hypoglossal nerve accompanied by the venae commitans. Got it right? Okay. And then what are the other nerve that you see here? You see the submandibular ganglion here. The submandibular ganglion is suspended by lingual nerve. Okay. Now the lingual nerve has an important relation with the submandibular duct. Yeah, the Wharton's duct. So initially it will be like lateral to it, below it, and then wind around its lower border. This is called the triple relation of the duct with the lingual nerve. Any other nerve you see here? This is the styloid process. You get to see the styloglossus muscle coming from here. You get to see the stylopharyngeus. Okay. The nerve accompanying the stylopharyngeus is glossopharyngeal nerve. Okay. So far, what are the things you have identified here? So you know the hyoglossus muscle, okay? You have seen the styloglossus muscle, stylopharyngeus muscle. This is your genioglossus muscle that forms the bulk of the tongue. And below the genioglossus, you get to see the geniohyoid. Apart from that, I'm going to show you two other important muscle here. You see the hyoid here. From the hyoid, you see some fibers originating and going backwards. This is the middle constrictor. Now, above the middle constrictor, you see another muscle here. This is your superior constrictor. So, okay with all the muscles that you have seen here? Can you tell me what is one? Hyoglossus. Two, genioglossus. Three, geniohyoid. Four, styloglossus. Five, stylopharyngeus. Six, middle constrictor. Seven, superior constrictor. Got it right? Now let's move on to the nerves that you see here. This one here is hypoglossal nerve accompanied by venae commitans. Two is lingual nerve. Three is your glossopharyngeal nerve, right? So submandibular duct also you have seen. Yeah, the submandibular duct actually begins from the deep part of the superficial part of the submandibular gland. What else do you get to see here? Anything more? Yeah, the red color ones that you get to see here. This is the lingual artery. Remember, we saw that the lingual artery is divided into three parts. By which muscle? Hyoglossus, right? So this is the first part of the lingual artery from the origin to the posterior border of hyoglossus muscle. What is the name of the branch arising from here? It will give rise to the suprahyoid branch. The second part of lingual artery, you can see it going beneath the hyoglossus, giving rise to dorsal lingual branches. This is the third part of the lingual artery. Okay, it will give rise to the sublingual branch that will be accompanied by the lingual nerve. Right? So, what is the question there? The structure which lies beneath hyoglossus is second part of lingual artery. Okay, so here you can see that the hyoglossus muscle is cut above and below. This is your first part of lingual artery. The second part is seen because hyoglossus has been cut. The third part, you can make out the submandibular duct shown in green color here. This is your lingual nerve, submandibular ganglia, the hypoglossal nerve, right? Here also you can try to identify the muscle seen here. Okay, hyoglossus, genioglossus, geniohyoid, and then this one for styloglossus. Stylopharyngeus is this one. This is your stylohyoid. Okay. This will be your middle constrictor, superior constrictor. Which of the following structures pass through sinus of Morgagni? What is sinus of Morgagni? The space between the base of the skull and the superior constrictor muscle. Okay. I want you to understand this picture. So, this is the base of the skull here. Okay. So, as I told you, what are the layers from outer to inner in case of pharynx? You have the buccopharyngeal fascia. If you open the buccopharyngeal fascia, what will you come across? The constrictor muscles. If you cut through the constrictor muscles, next will be the longitudinal muscles. And then the submucosal coat is called the pharyngobasilar fascia mucosa. So these are the layers from outer to inner. Buccopharyngeal fascia, constrictor muscle of pharynx, longitudinal muscle of pharynx, pharyngobasilar fascia mucosa. Okay. And so that's what you're seeing here. These are the constrictor muscle of pharynx. The superior constrictor, middle constrictor, inferior constrictor. Okay. This is the hyoid bone from which the middle constrictor comes. The superior constrictor comes from the pterygomandibular raphe, the medial pterygoid plates, all that. The inferior constrictor has two parts. From the thyroid cartilage, thyropharyngeus. From the cricoid, you'll have the cricopharyngeus. Okay. The pulsion diverticulum that you see between the two is called the Zenker's diverticulum or the Killian's dehiscence. Okay. Hope you remember that. Now coming to the structures passing between these constrictor muscles. So this one that you see here, the space between the superior constrictor and the base of the skull, that will be traversed by the cartilaginous part of the auditory tube, the levator palatine muscle, ascending palatine artery, palatine branch of ascending pharyngeal artery. I'll write it down. The cartilaginous part of the auditory tube, the levator palatine muscle, ascending palatine artery, the palatine branch of ascending pharyngeal artery, right? Between the superior constrictor and the base of the skull. What passes between the superior constrictor and the middle constrictor? Can you see and tell here? This is your styloid process. This is your stylopharyngeus. What is the nerve accompanying it? The glossopharyngeal nerve. So between the superior constrictor and middle constrictor will be stylopharyngeus muscle with the ninth nerve. Okay, now you see here, this is your hyoid, this is thyroid, I told you. What lies between the two? The thyrohyoid membrane. So between the middle constrictor and the inferior constrictor, what will you get to see? The structures piercing thyrohyoid membrane, we have seen superior laryngeal vessels and the internal laryngeal nerve. Below the inferior constrictor in the tracheoesophageal groove, you'll get to see the recurrent laryngeal nerve and the inferior laryngeal vessels. So in this picture that I want you to identify is the superior constrictor, middle constrictor, thyropharyngeus part, cricopharyngeus part, stylopharyngeus and the glossopharyngeal nerve. Okay. Here you can see the auditory tube, cartilaginous part, the levator veli palatine. Okay. The salpingopharyngeus muscle, palatopharyngeus muscle, stylopharyngeus muscle. So only when you remove the constrictors, you'll get to see the three longitudinal muscles. Okay. All the muscles of the pharynx are supplied by pharyngeal plexus contributed by 9, 10 and cranial part of accessory nerve mainly, except tensa palatine, except the stylopharyngeus that's innervated by glossopharyngeal nerve. Coming to the next question, the pointed structure is found in which of the following? So what is the structure pointed out? Any idea? This is the histological image of microscopic structure of dorsal root ganglia. So now what is the one pointed out? Those are your pseudo unipolar neurons. So where do you get to see the pseudo unipolar neurons in the body? Yes. So we had a batchmate called as Guru Vaidya Ganapati. Okay. We used to call him GVG. That's the mnemonic you have to remember for pseudo unipolar neurons. You get to see it, of course, in the dorsal root ganglion. You also get to see it in the mesencephalic nucleus. Mesencephalic nucleus of trigeminal nerve. Okay. Geniculate ganglion. The superior and inferior ganglion of vagus. The ganglion of glossopharyngeal nerve. Okay. Please remember, these are the areas where you get to see pseudo-unipolar neurons. Now, this is the dorsal root ganglia. This is sympathetic ganglia. So how will you identify or differentiate between the two? Here, pseudo-unipolar neurons, of course. These are larger in size, isn't it? The cell bodies are larger in size and they are seen as clumps in groups, right? And the satellite cells, okay, they form a complete capsule there. Here, these are multipolar neurons, cell bodies, which are smaller in size. They are scattered. Also, they have eccentrically placed nucleolus. And then here the satellite cells, because it's multipolar, it cannot form a complete capsule. Okay, oculomotor nerve. All will occur in damage to oculomotor nerve except. So what are the muscles of eyeball? You have the four recti, superior recti, inferior recti, medial recti, lateral rectus, the two obliques, superior oblique, inferior oblique, levator palpebrae superioris. All of you must be knowing SO4. Superior oblique is supplied by trochlear nerve. Lateral rectus is supplied by abducens nerve. All the others are going to be supplied by oculomotor nerve. In addition, do remember that the oculomotor nerve, the nerve to inferior oblique, yes, through the short, it's going to relay in the ciliary ganglion, and the short ciliary nerves coming out of it also supplies the sphincter pupillae, the parasympathetic component, and the ciliaris muscle, right? Please remember that, okay? Now, what is the action of all this? Levator palpebrae superioris is going to elevate your upper eyelid. So, if goes for paralysis, that will cause ptosis. Of these six muscles, how to remember the action? Medial rectus is going to cause adduction of eyeball. Lateral rectus will cause abduction of eyeball. So, leave that. Now, the confusion will be between superior rectus, inferior rectus, superior oblique, inferior oblique. Okay, how to remember the action of all this? Please remember the recti adduct, obliques abduct, superiors intort, inferiors extort. So what is the action of superior rectus? Intorsion, adduction of eyeball. Inferior rectus will be, yes, extorsion, adduction. Superior oblique is going to cause intorsion and the oblique will be abduction. Inferior oblique will be extorsion and abduction. Okay. Now what is happening to the damage to oculomotor nerve? Remember these five terms. Ptosis, external squint, because of unopposed action of lateral rectus, which is going to be supplied by abducens nerve. Dilated and fixed pupil, because of the loss of the parasympathetic component. And apparent proptosis, because everything is sort of paralyzed, the eyeball will be sort of protruding. Paralysis of the muscles. Loss of accommodation. Okay. These are the features of oculomotor nerve palsy. Pedal. Identify the incorrect statement about the pointed structure. What is the pointed structure here? The right coronary artery. What are the three coronary sinus there? There is one anterior. What are the three aortic sinus? Anterior aortic sinus, two posterior aortic sinus, right? The right and left. The anterior aortic sinus will give rise to right coronary artery. The left posterior aortic sinus will give rise to left coronary artery. The right posterior aortic sinus is called the non-coronary sinus. Okay. Now they have asked, identify the incorrect statement about the pointed structure. It arises from anterior aortic sinus, supplies SA node. It doesn't supply the right bundle branch. Of course, depending upon which artery gives rise to posterior interventricular branch, you call it as coronary predominance. Most of the time, posterior interventricular branch will arise from right coronary artery. Now coming to the blood supply of heart, you see the right coronary artery. As it comes, what are these veins which are crossing it? They are called the anterior cardiac veins. Okay, just helping you to identify anterior cardiac vein. The branches of the right coronary. This branch, you can see it supplying the infundibulum of the right ventricle. That's called the right conus artery. And then you can see branches coming from the right coronary to supply the sternocostal surface of the right ventricle. It gives rise to the right marginal artery. Okay, you can see branches coming from it to supply the right atrium. Yeah, and this right atrial branches, they also get to supply the SA node. Okay, I'll show you another picture now going behind. You can see the right coronary going to occupy the posterior part of atrioventricular sulcus. It gives rise to the posterior interventricular branch, and then it crosses the crux of the heart. It goes to the left side to anastomose with the left circumflex branch. This part of it, you can see branches arising from the posterior interventricular branch to supply both diaphragmatic surface of right ventricle, left ventricle. More important, okay, the first branch is going to give rise to the AV nodal branch. So you have the posterior interventricular branch. Branches coming from the posterior interventricular will supply posterior 1/3 of the interventricular septum. Only the 1/3, posterior inferior 1/3. So on the whole, if you get to see right coronary artery, it supplies which chambers of the heart? The right atrium, most of it. The right ventricle, most of it. Part of the left ventricle, okay, on the diaphragmatic surface, and then postero-inferior 1/3 of the interventricular septum. Conducting system, it supplies the SA node, it supplies the AV node, right? Now coming to the left coronary artery. The left coronary artery that you see here, it has a very short trunk. It's going to divide into left anterior descending, anterior interventricular branch, and the left circumflex artery. What is going to happen to this left anterior descending artery? It will give rise to the left conus artery to supply the infundibulum of the right ventricle. Branches coming from the anterior interventricular branch will supply the sternocostal surface of the right ventricle, left ventricle. Okay, these are called the diagonal branches. And then it will give rise to the left marginal artery. Okay, it goes behind to anastomose with the right coronary artery. Now the chamber of the heart supplied by the left coronary artery. The anterior interventricular branch, it supplies antero-superior 2/3 of the interventricular septum, right? So this interventricular septum is the one which is going to lodge your bundle of his right bundle branch, left bundle branch. Okay, so it will supply the left atrium, left ventricle, part of right ventricle. Sometimes, okay, it can give branches to supply the right atrium also, antero-superior 2/3 of the interventricular septum, the right bundle branch, okay, and the left bundle branch. All that will be supplied by left coronary artery. Okay, so we have seen answer to this question. I also want to tell you about the coronary sinus. Yeah, so the coronary sinus, can you identify the veins here? The vein which accompany the anterior interventricular branch. Yes, what is it? That's the great cardiac vein, which receives the left marginal vein. As I told you, these are the anterior cardiac veins. The anterior cardiac veins will open directly into the right atrium. This one accompanying the posterior interventricular branch is the middle cardiac vein. This one is the oblique vein of left atrium. This is the posterior vein of posterior vein. All these will open into the coronary sinus. Okay. Coming to the next question. Middle meatus receives the opening of all the following except. Okay. Can you tell the answer here? Or we'll go to the discussion and come back. So this is the lateral wall of the nose where you get to see the three concas there. Inferior concha, middle concha, superior concha. So if you remove the concha, the space underneath, you're going to call it as the meatus. The inferior meatus receives the opening of nasolacrimal duct. Okay. This is the region of middle meatus. So the middle meatus, if you explore, you'll get to see the middle concha. If you remove, you'll get to see a bulge-like appearance there. That is called the bulla ethmoidalis. Underneath the bulla ethmoidalis will be the middle ethmoidal ascels. So the middle ethmoidal ascels will open onto the surface of bulla ethmoidalis. And beneath the bulla, you can see a depression there. That is called as the hiatus semilunaris. Okay. Hiatus semilunaris. This hiatus in the floor will receive the opening of maxillary sinus. Okay. And then it will extend upward. Okay. It's called the ethmoidal infundibulum. The wall of the ethmoidal infundibulum will receive the opening of anterior ethmoidal sinus. And the top of the ethmoidal infundibulum will receive the opening of frontal sinus. So what are the sinus opening into middle meatus? Frontal sinus, anterior ethmoidal, middle ethmoidal, maxillary. Okay. Frontal, anterior, maxillary, middle ethmoidal sinuses. Now, the space below the superior meatus, this space here that you see here, that's called the superior meatus. That will receive the opening of posterior ethmoidal ascels. The space above, okay, here, this is called the sphenoethmoidal recess. Above the superior meatus, sphenoethmoidal recess, that will receive the opening of sphenoidal sinus. Okay, guys? Okay. Following removal, this has been asked recently, following removal of trigeminal ganglion, there will be temporary loss of taste sensation over. So the nerve supply of tongue is very important. Motor, sensory. Okay. So motor we have seen. Sensory, you know, there is general sensation and taste sensation. Motor, all the muscles of the tongue are supplied by hypoglossal nerve except palatoglossus, that's going to be supplied from your pharyngeal plexus. Now coming to the sensory nerve supply, we are going to divide it into anterior 2/3, posterior 1/3, and the posterior most part. So the anterior 2/3 of the tongue, excluding the circumvallate papillae, okay, the general sensation to anterior 2/3 of the tongue is by lingual nerve. Okay, the taste sensation to the anterior 2/3 of the tongue, excluding the circumvallate papillae, will be from chorda tympani, branch of facial nerve. Now the circumvallate papillae along with the posterior 1/3 will be receiving innervation from glossopharyngeal nerve, both general and special senses, the taste sensation. The posterior most part of the tongue, including the region of vallicula, that will be innervated by the internal laryngeal nerve, which also innervates the pyriform fossa. Okay. Now this is again another important question. Abduction of vocal cord is done by which one? So I will label the options now. Let's have this is A, this is B, this is C, this is D. So the abduction of vocal cord is done by. Okay. So if you see the vocal cord, the main tensor of vocal cord is cricothyroid muscle. The main abductor of vocal cord is your posterior cricoarytenoid. So you have to identify the muscles now. Yes. So this is your thyroid cartilage. This is your cricoid cartilage. This one bridging the thyroid and the cricoid, that is your cricothyroid muscle. Okay. That's the cricothyroid muscle, which is the tensor. Now this one here that you see, this is the posterior cricoarytenoid. Okay, this is the muscular process of arytenoid. Inserting posterior into it is a posterior cricoarytenoid, and from front it's receiving this muscle, that's the lateral cricoarytenoid. Okay, now this one crossing like that, this is your oblique arytenoid, and beneath the oblique arytenoid, the unpaired muscle of larynx, that's the transverse arytenoid. Okay, and then this aryepiglottic fold I told you, this is your aryepiglotticus muscle. And here, this one just lateral to your ocal ligament, this is your ocalis muscle. Just lateral to it, that's your thyroarytenoid muscle. Okay, so what is A here? Posterior cricoarytenoid. B, lateral cricoarytenoid. C, cricothyroid. D is thyroarytenoid. The answer is the abductor of vocal cord, posterior cricoarytenoid, which is also called the safety muscle of larynx. Okay. Which of the following is not associated with external oblique muscle? So you know that the lower border of the upper neurosis of external oblique is thickened to form the inguinal ligament or the Paupart's ligament. Now it's going to have some extensions, isn't it? It will give rise to the lacunar ligament, pectineal ligament of Cooper, reflected part of inguinal ligament. Okay, and the opening in the external oblique upper neurosis will be superficial inguinal ring. Conjoint tendon is formed by the union of fibers of both transverse abdominis and internal oblique and not external oblique. Okay. Now, what is this triangle of Petit? Have you come across that term? Yes, in your upper limb. Can you see here? So, this is your external oblique muscle. This is the anterior border of latissimus dorsi. Okay. And this is the iliac crest. So anteriorly by the posterior border of external oblique, posteriorly by the anterior border of latissimus dorsi, apex where the two meet, the base is formed by the iliac crest. In the floor, you get to see the internal oblique muscle. Okay, so this area is called the lumbar triangle of Petit, a potential site of herniation. Now, this is an image-based question. I want you to identify whatever you see here, the brain stem. Okay, so you know this is your medulla. This is pons. This is the region of midbrain. Okay, okay with that? So what is that you get to see in the medulla? This is the anteromedian fissure. Okay. Here topmost you'll have that foramen cecum. Lower part decussation of your pyramidal tract. The bulge that you get to see here, this is called pyramid. What lies underneath the pyramid? Your corticospinal fibers. Okay. And then you have the anterolateral fissure through which you can see nervelets emerging out, isn't it? Yeah. This is your anterolateral fissure. Yeah, the nervelets emerging out here will be this is your spinal nerves, okay? This one, a bulge that you see here, this is olive. We saw pyramid, another bulge lateral to it, that is olive. It's produced by the inferior olivary nucleus. Okay. Now, anterior to olive, you see a group of rootlets emerging out. That's the hypoglossal nerve. Behind the olive, you see nerves coming out, 9, 10, and the lowermost is your 11th nerve. 9, 10, and the 11th nerve rootlets. Okay. Now, yeah. And behind the olive, behind 9, 10, 11, you get to see the inferior cerebellar peduncle. So that's the anterior aspect. This is your pontomedullary junction. You get to see the 6th nerve, 7th nerve, 8th nerve. Okay, this is the choroid plexus of your 4th ventricle. This is the flocculus of cerebellum. So CP angle, you get to see the 7th nerve, 8th nerve, flocculus of cerebellum, choroid plexus of 4th ventricle. Okay, these 4 structures related to CP angle. Now, yeah, this is pons. This is the basilar sulcus that will lodge your basilar artery. You get to see some nerve coming out here. The thickest of the cranial nerve, the trigeminal nerve. Whatever you see lateral to it, that will be the middle cerebellar peduncle. Okay. Now we have seen 12, 9, 10, 11, 6, 7, 8. Fifth one also we have seen. This is the region of midbrain I told you. From the medial aspect of the midbrain, you get to see the 3rd nerve emerging. And from the dorsal aspect of it, that's your trochlear nerve, the 4th nerve. Okay. So this part is the crus cerebri part of cerebral peduncle. And here is the region of your interpeduncular fossa. This is the posterior perforated substance. Okay, the striate branches piercing the gray matter. This is your mammillary body. This bulge that you get to see here, that's the tuber cinereum. That's the stalk of your pituitary. This is the anterior perforated substance, okay? Here, postromedian sulcus. This is the gracile tubercle, okay, where the fasciculus gracilis ends. This will be cuneate tubercle where the fasciculus cuneatus ends. Okay, this is the region of your 4th ventricle. What you see here is the trochlear nerve. Yeah, emerging out from that's the only nerve, cranial nerve emerging from the dorsal aspect of the brainstem. Region of your inferior colliculi, superior colliculi, the pineal gland. Okay, the medial and the lateral geniculate bodies. You can make out the dentate nuclei of cerebellum here. Okay, now coming to the question, which among the following will not pass through the pointed structure? What is the pointed structure here? What is this we saw? Pyramid. This is olive. Just lateral to the olive, what you see here will be inferior cerebellar peduncle. Okay. So, you know, there are 3 cerebellar peduncle. The inferior cerebellar peduncle connects the medulla with the cerebellum. Middle cerebellar peduncle connects the pons with the cerebellum. Superior cerebellar peduncle connects the, yes, midbrain with the cerebellum. Now, there are afferents and efferents passing through it. There's always one commonly asked question there. Okay. What are the afferents passing through the inferior cerebellar peduncle? Normally we say popcorn, isn't it? This is pop carve. Just instead of N, we have R. So, the posterior spinocerebellar tract, olivocerebellar tract, yeah, olivocerebellar tract, yes, cuneo-cerebellar fibers, anterior external arcuate fibers, reticulocerebellar, vestibulocerebellar. Okay, please remember the mnemonic POPCARV. Efferents coming out through the inferior cerebellar peduncle will be cerebello, vestibular, cerebello, reticular, cerebello, olivary. Okay, I'll erase it. Coming to the middle cerebellar peduncle, there are only afferents passing through it. And what is that? The pontocerebellar fiber. Okay. Superior cerebellar peduncle, again, CHATT, chart. Yeah. Inferior cerebellar peduncle, pop card. Okay, this is chart. So what are they? Cerebellar fibers. Yes. Hypothalamo-cerebellar fibers. Anterior spinocerebellar tract. Okay. Tectocerebellar, trigeminocerebellar. The efferents will be cerebello-rubral, cerebello-reticular, cerebello-olivary. But the main efferents will be from in your dentate nucleus, dentato-rubral, dentato-thalamic fibers. Okay. The most commonly one asked is about the anterior spinocerebellar and the posterior spinocerebellar. Remember, inferior cerebellar peduncle, yeah, convey the afferent posterior spinocerebellar. Superior cerebellar peduncle conveys the anterior spinocerebellar tract. Okay. Facial colliculus includes, if you read the options, you'll be getting more confused. If you know the answer, you can easily tick it out. Okay. So where do you get to see the facial colliculus? The pontine part of the floor of your fourth ventricle, right? It's produced by the abducens nucleus and the internal genu or the motor fibers of the facial nerve winding around it. Can you make it out here? That's the region of facial colliculus. So as you see here, this is your floor of the fourth ventricle, also called the rhomboid fossa. Yes. So if you see the structures here, this will be the vagal triangle that lodges the dorsal nucleus of vagus or the motor nucleus of vagus. It also has the area for vomiting, the area postrema. Okay, two things there. Above that is the hypoglossal triangle that has the hypoglossal nucleus. Just lateral to it, you have the inferior vestibular area. This is your stria medullaris. And above, this will be the superior vestibular area. This is the facial colliculus. Okay. Sulcus limitans, locus ceruleus. Yeah. Above this medial eminence. So this facial colliculus is produced by the abducens nucleus and the motor fibers of the facial nerve. It's also called the internal genu of the facial nerve. Okay. So this is the fibers now. Identify the type of fiber marked in the given diagram. A is long association, B is short association, C is projection, D is commissural fiber. Okay, this was another very important image-based question. The arrow pointed out, it lies in the region of internal capsule. Okay. So we'll quickly classify the type of fibers. There are three types of fibers, isn't it? So the fibers, the white matter that connects the gyri, okay, the identical gyri within the same hemisphere is association fiber. Within the opposite hemisphere, that will be commissural fiber. From the cortical to the subcortical area to the brainstem, spinal cord, that will be projection fiber. So short association fiber are the one which connect adjacent gyri, okay, by hooking around the sulcus separating the two. The long association fiber is what's shown here. The best examples are uncinate fasciculus. What does uncinate fasciculus do? It connects the orbital cortex of the frontal lobe, the motor speech area with the temporal lobe by winding around the stem of the lateral sulcus. Okay. And then you have the cingulum. Cingulum connects the paraterminal gyrus with the uncus here. Okay. And then superior longitudinal fasciculus will connect the frontal lobe with the occipital as well as the temporal. Inferior longitudinal fasciculus will connect the occipital with the temporal. There's one more, the fronto-occipital bundle. This fronto-occipital bundle, similar to superior longitudinal fasciculus, will connect the frontal with the occipital. Okay. How to differentiate the superior longitudinal fasciculus from the fronto-occipital bundle? This fronto-occipital bundle will lie on a deeper plane and is separated from the superior longitudinal fasciculus by the corona radiata. Okay, got it? Coming to the commissural fiber, the corpus callosum is the largest of your commissural fiber. Okay, so I'm sure you know the parts of the corpus callosum there. Yeah, so this is anterior, this is posterior, this is rostrum, the bend is the genu, this is body, this is splenium. Okay, what you get to see here is the fornix. This is the cavity of your lateral ventricle. Okay, you can make out the interventricular foramen here. This is your thalamus. This is the region of hypothalamus, cerebral aqueduct, midbrain, pons, medulla. Okay, so this is in this here. Here again you get to see the corpus callosum there. This is the fornix. This is your septum pellucidum. This is again the corpus callosum. So corpus callosum, it connects most of the identical areas of both the hemisphere. What are the other commissural fiber? Anterior commissure connects the lower anterior part of the temporal lobe of both the hemisphere. Posterior commissure, it connects the superior colliculus, pretectal nucleus, interstitial nuclei of both the hemispheres. Habenula commissure, it connects the habenula nuclei of both the hemispheres. There's one more, the commissure of the fornix, okay, that connects the crura of fornix of both the sides, okay. So this fornix, if you see, it begins as from a hippocampus as alveus, fimbria, crura. They are connected to form the body. The body will again split into columns and finally reach the mammillary body. Okay, this fornix is not only an example for commissural fiber, it is also an example for projection fiber. Okay, from the cortical to the subcortical, mammillary body is part of your hypothalamus. Some of the fibers also reach your cingulate bundle behind the splenium. They contribute to the association fibers. Okay, so fornix comes under commissural, projection as well as association fiber. Now coming to internal capsule, yeah, that's an example for projection fiber. So what are the structures you can identify in this image? Yes, you can make out the corpus callosum, septum pellucidum, fornix, the anterior horn of the lateral ventricle, This will be posterior horn of the lateral ventricle. This is your third ventricle. Okay. Now what is this? This is the head of your caudate nucleus. Okay. This will be tail of caudate nucleus. Okay. What is that you get to see on either side of the third ventricle? This is your thalamus. Yes. Now this is your lentiform nucleus, outer putamen, inner globus pallidum. Now this entire thing is your insular cortex. The gray matter of the insular cortex, the white matter of the insular cortex is also called the extreme capsule. This gray matter that you see here wavy, that is the claustrum. The one white matter inner to it, that's the external capsule. Okay. This is the choroid plexus in the posterior horn of lateral ventricle. A knife wound to the cervical portion of spinal cord in the pointed area will affect fine touch carried from which part of the body. So, this is the gray matter. This is your white matter. You're going to call it as funiculus, isn't it? Dorsal funiculus, anterior funiculus, lateral funiculus. What is the tract? Yeah, the ascending tract that you get to see in the dorsal funiculus, dorsal column pathway, fasciculus gracilis, fasciculus cuneatus. Fasciculus gracilis and cuneatus, what type of sensation do they carry? They carry, yes, discriminative touch, 2-point discrimination, stereognosis, vibration, proprioception. But what is the difference between fasciculus gracilis and cuneatus? Fasciculus gracilis will carry the sensation from the lower part of the body. Yes, from the lobulum, the sacrum, sacral segment of the spinal cord, from the lumbar and the lower thoracic. Whereas fasciculus cuneatus will be from the upper thoracic and cervical region. Okay. Yeah. And then you get to see the spinothalamic tract here, the anterior and the lateral spinothalamic tract. Lateral spinothalamic tract will carry the sensation of pain and temperature. Anterior spinothalamic tract will carry the sensation of crude touch and pressure. Okay. Coming to the descending pathway, you get to see the corticospinal, rubrospinal, vestibulospinal, everything. Yeah. Now, the arrangement of the fibers in these tracts is important. Okay, that's what is related to our MCQ. So, I told you dorsal column, the sacral fibers are medial most, the cervical fibers are lateral most. So, where is the knife put? Over the medial part, isn't it? So, from the lower limbs, okay. And then arrangement of fibers in the spinothalamic tract is also important. The sacral fibers are in the periphery. The cervical fibers are innermost. And even in a corticospinal tract, the sacral fibers will be arranged towards the periphery and the cervical fibers to the innermost. Okay. So depending upon the injury that you'll know that which part of the body is going to be involved. Ligaments pierced during lumbar puncture includes all except. So lumbar puncture, is done to withdraw the CSF, and the best point is to put the needle between the L3, L4 disc, isn't it? Structures pierced by the needle during lumbar puncture. That's the mnemonic tag. Okay. So, Sleepy Sarah slept in lab after dining asparagus. Skin, superficial fascia, yes. Then your ligament. What is that? Supraspinous ligament. Interspinous ligament. Yes. And then ligamentum flavum. Ligamentum flavum, it connects the lamina of the vertebral bodies. Okay. And then you have the loose areolar tissue in the epidural space, and then the dura mater, subdural space, and finally the arachnoid mater. Okay, please remember the mnemonic. It's a frequently asked question. Sleepy Sarah slept in lab after dining asparagus. Okay. So posterior longitudinal ligament actually lines the posterior aspect of the body. Yeah. Ligamentum flavum is the one that you see pink here. This is the needle. Can you see here? Skin, superficial fascia, the supraspinous ligament, interspinous ligament, ligamentum flavum. Accessory meningeal artery passes through, any idea? Yeah. So what passes through foramen rotundum? Maxillary nerve. Foramen ovale, male structures. What are they? Mandibular nerve, accessory meningeal artery, lesser petrosal nerve, emissary vein. Right? Foramen spinosum, middle meningeal artery, and nervus spinosum. Jugular foramen, you know, it has three compartments. Anterior compartment, intermediate compartment, and posterior compartment. So the anterior compartment, inferior petrosal sinus. Posterior compartment, the sigmoid sinus is going to continue as internal jugular vein. And through the middle compartment, 9, 10, 11 cranial nerve. Foramen lucidum, actually nothing passes through. Okay. It receives the upper opening of the carotid canal and the posterior opening of pterygoid canal. So we'll see the images there. Here. So this is the middle cranial fossa. This is your foramen rotundum. This is foramen ovale. This is foramen spinosum. On either side of the body of the sphenoid, that will be the foramen lucidum. Here on the base of the skull also you can see that this is the body of the sphenoid. On either side of the body of the sphenoid, this is foramen lucidum. Okay, this is spine of the sphenoid. So closer to that will be foramen spinosum. In front of that, foramen ovale. The base of the skull, you can't see the opening of foramen rotundum because it will open into pterygopalatine fossa. The given tissues found in epiglottis, intervertebral disc, costal cartilage, acetabular labrum. This was asked recently, isn't it? What is this tissue? Hyaline cartilage. Yes? What are the areas you get to see hyaline cartilage? Can you tell me? Fetal skeleton. Okay. Articular cartilage of your synovial joint. Nasal septum. Yeah. Thyroid cartilage. Cricoid cartilage. Most of the arytenoid. Yes. All these are made up of hyaline cartilage. Epiglottis is an example for elastic cartilage. Intervertebral disc and acetabular labrum is made up of fibrocartilage. So now how to differentiate between fibrocartilage, elastic cartilage and hyaline cartilage? Okay, so easy. This is your fibrocartilage. There is no perichondrium. Okay, so you can see the perichondrium here in both elastic cartilage and hyaline cartilage. Okay, and then between the hyaline cartilage and elastic cartilage, you can see that hyaline cartilage, the matrix is homogeneous. Homogeneous basophilic matrix. Okay, and the chondrocytes here, they are arranged as isogenous groups. What do you mean by isogenous groups? The daughter cells derived from the parent cell, they all will remain as one single colony. Okay, isogenous groups will be present in both elastic cartilage and hyaline cartilage, but the isogenous group in hyaline cartilage will be more in number. In elastic cartilage, there will be only 2 to 3 cells. Okay, so here you can see the matrix is homogeneous. You can't make out the collagen fibers as such. But here in elastic cartilage, you can make out the branching elastic fibers. Okay, and here in fibrocartilage, you'll get to see bundle of collagen fibers running in a particular direction along the direction of stress. So elastic cartilage, remember 3 is the pinna of the ear, the epiglottis, and eustachian tube. Okay, pinna of ear, epiglottis, eustachian tube. These are made up of elastic cartilage. In addition, corniculate and cuneiform cartilage of larynx. Okay, fibrocartilage, the labrums, glenoidal labrum, acetabular labrum, intervertebral disc, and the in sternoclavicular joint and temporomandibular joint, the articular cartilage is made up of fibrocartilage. Okay. Normally in synovial joint, articular cartilage is made up of hyaline cartilage. But in sternoclavicular joint and temporomandibular joint alone, the articular cartilage is going to be made up of fibrocartilage. Okay. The histology of the given picture leads to which of the following speech disorder? Okay. So here, what is this you get to see here? That's the picture of cerebellum. Yeah. I've put a picture comparing cerebrum and cerebellum. So this is cerebrum. This is cerebellum. Right? So in the cerebellum, if you get to see, and the two cells, important cells that you have to identify here is, in the cerebrum, these are the pyramidal cells. And in the cerebellum, you can make out nice flask-shaped cells here. These are called the Purkinje cells. Right? So if you see the cerebellar cortex, yeah, if you see the cerebellar cortex, there's 3 layers from outer to inner: the molecular layer, the middle Purkinje layer, and inner granule cell layer. In the molecular layer, you'll get to see the basket cell, stellate cell. You see the Purkinje cell here. The dendrites of the Purkinje cell will form a nice arborization here. Okay, in the outer molecular layer. Yeah, and then the granule cell of the granule layer, it will send its axon to the outer molecular layer that will sort of bifurcate as a T. That will also be present in the outer molecular layer. Okay. So the basket cell, stellate cell, dendritic arborization of the Purkinje cell, as well as the axon, the T bifurcation of the granule cell. All that you'll see in the molecular layer. And then here, the ganglionic cell layer is nothing but a single layer of large flask-shaped Purkinje cell layer. Okay, and the dendrites will go to the outer molecular layer, whereas the long axon of these Purkinje cell, which form the sole output of the cerebellum, will go and will synapse with the intracerebellar nuclei. Okay, and then in the granular layer, you'll get to see 2 types of cells. One big one called the Golgi cell. The Golgi cells are large, prominent, but scanty in number. And then the small granule cells. Okay. Now there are 2 types of afferents coming to the cerebellum: the climbing fiber and the mossy fiber. Okay. The climbing fibers, they come from the olivary nucleus. Yeah. So these are the olivocerebellar and parolivocerebellar fibers. Okay. What happens is that these climbing fibers, they ascend up and they synapse with the Purkinje cell in the ratio of 1:1. So each climbing fiber can only stimulate 1 Purkinje cell. Okay. Whereas the mossy fiber, what will happen? The axon terminals of the mossy fiber, all are the afferents coming to the cerebellum, comes under mossy fiber. So the mossy fiber terminals, okay, they will synapse with the dendrites of the Golgi cell and the dendrites of the granule cell and the axons of the Golgi cell. Dendrites of granule cell, because the axons are going up, and the axon terminals of the Golgi cell. Okay, this entire thing is called the cerebellar glomerulus. The cerebellar glomerulus is covered by a special type of neuroglial cells called Bergman cells. Okay. Now, because of this, one mossy fiber through a granule cell, okay, will be synapsing with around 30 to 45 Purkinje cells, okay, indirectly. Now, of all these cells, okay, only the granule cells are excitatory in function, right? All the other cells are inhibitory, okay. The Purkinje cells from the cerebellum will end in intracerebellar nuclei. Okay. The market cell inhibits which of the following? The Purkinje cell will inhibit your deep cerebellar nuclei. Okay. Except the granule cell, all the others are inhibitory in function. We saw the cerebrum, remember? So the layers of the cerebrum from outer to inner will be outer molecular layer. So we have a friend called Jnana Prabha. We used to call her GP. So remember that granular, pyramidal, okay? Outer granular layer or external granular layer, external pyramidal layer. Inner granular layer, inner pyramidal layer, and lastly you'll have the multiform layer, okay? So here you'll get to see the pyramidal cells. The pyramidal cell size will increase as we go deeper, and the larger pyramidal cells, the giant pyramidal cells are called the bed cells. And here they'll frequently ask you, where do you get to see, which layer you get to see, the outer band of Baillarger or inner band of Baillarger. These bands of Baillarger are nothing but the compact bundle of white fiber, the axons, okay, that are traversing through that layer. Okay, remember, 5th year you do your internship. 5I. So in the 5th layer, you get to see the inner band of Baillarger. So 4th layer, you will get to see the outer band of Baillarger. Okay. Yes, guys. So we're winding up with today's session. Any doubt, get back to me. Thank you.